Thank you all so much for joining us. This is our final Lunch and Learn of 4 that we hosted. This one is all about accessible and alternative healthcare delivery. So welcome. Sherry Landis, our executive director, was unable to join us today, so I am going to kick things off. My name is Emma Nolan. I'm the manager of government relations and healthcare initiatives here at the ARC of Pennsylvania. And I'm going to introduce a little bit about what we've been doing over at the ARC of PA in terms of our initiative to address COVID-19 healthcare disparities among people with disabilities. So a few years back when COVID emerged, there was a really big apparent discrepancy going on in terms of disability inclusive healthcare. So we have a project funded by the Pennsylvania Department of Health to really look towards developing disability inclusive healthcare across the state. So in order to do this, we organized a COVID-19 health disparities task force, which involved a lot of different stakeholders across the state, some people with lived experience of disability, healthcare providers, stakeholders, disability stakeholders, to really have some robust conversations about what needs to happen across the state. We also had regional community work groups, which consisted of hundreds of individuals across the state, led by our chapters. We had over 400 individuals with disabilities, family members, caregivers, health professionals across diverse ethnic, racial, and rural populations that we spoke to throughout the course of this project. Of course, we have the ARC of PA admin team and our local chapters that participated. And of course, this work could not have been possible without the funding from the Pennsylvania Department of Health. So today's focus, we're going to take a look at a disability inclusive healthcare system in our state that really exemplifies what we see as disability inclusion. So making sure everybody has the same opportunity to participate in every aspect of life to the best of their abilities and desires. Disability inclusion allows for people with disabilities to take advantage of the benefits of the same health promotion and prevention activities experienced by people who do not have a disability. So today's agenda, we're going to go over a little bit about what this health disparity looks like across the state for people with disabilities and how this recommendation came to be before moving into our practice panel today and moving into our Q&A. So the picture you see on the right is the COVID-19 healthcare barriers among people with disabilities report that was released back in 2022. And this is a report that I'm sure will be put in the chat momentarily that really talks about any barriers to healthcare that people with disabilities experienced throughout the state. And that's what we focused on the first year of this project. So why does this work matter, and why should this have such a big impact across the state? We know that 1 in 4 American adults has some form of a disability, and we know that the number of people with disabilities is only going to climb while our population ages and while the more and more people present with long COVID and those sort of symptoms that are really leading to a population experiencing high rates of disability. We also know that people with disabilities often experience health inequities that lead to poorer health outcomes. So adults with disabilities are 3 times more likely to have things such as heart disease, stroke, diabetes, or cancer than adults without disabilities. And some of these inequities can arise from conditions faced by people with disabilities, which include stigma or discrimination, poverty, limited education and employment opportunities, transportation barriers, and barriers faced in the health system itself. So what we did at the ARC of Pennsylvania was conduct a listening tour where we spoke to over 400 individuals with really unique experiences during COVID. And we tried to talk to as many people as possible with really diverse roles and experiences. So we had diversity by role, which included people with lived experience of disability, caregivers, and family members, as well as professionals in both the fields of disability and healthcare. We had diversity by disability, so making sure we had intentional outreach across physical, intellectual, developmental, behavioral or emotional, sensory impairment, and complex medical disabilities. We had diversity by race and diversity by location, so intentional outreach to both the Black, Indigenous, people of color or BIPOC community, and intentional outreach to rural settings. And throughout this entire conversation about barriers that people with disabilities experienced, we organized them by something called social determinants of health. And I'm sure many people on this call are aware of what those are, but a social determinant of health is anything in an environment where an individual works, plays, worships, learns, lives, that influences their health in some way, shape, or form. So these can be organized by those color statements that you see. So education, access, and quality, economic stability, social and community context, neighborhood and built environment, and healthcare access and quality. And all of these combined to really focus on the person and what they experience in terms of their healthcare. So now we're going to play a short clip from our solutions report that really focuses on what we mean when we say the importance of disability inclusive healthcare.
Well, the general public needs to be more understanding of people with disabilities. We're not second-class citizens, and we're not amazed anybody. We're just the same as anybody else. We just operate a little bit differently.
And that was a quote from one of our participants, Janet Minnick, who is a self-advocate from Allegheny County. Next slide, please, Rhonda. Thank you. Another quote from one of our participants, Sharon Janasic, who is an autistic adult and parent to a disabled child, also from Allegheny County. People with disabilities who have access needs weren't part of plans at the beginning. Honestly, sometimes not even by the end. So both of these quotes just show the importance of having a disability inclusive healthcare system to make sure that people with disabilities needs are part of planning, to make sure all policies are inclusive. And we're also going to play this clip shortly.
Disability mutual aid groups were being set up immediately and reactivated right at the beginning of this pandemic because we knew what was coming. We knew these were things would be a problem. We knew no one was solving that problem except for us. And it's kind of disheartening to realize, as great as the Commonwealth of Pennsylvania is, people with disabilities who have access needs weren't part of any of those plans at the beginning. Honestly, sometimes not even by the end. So making sure that people with disabilities are represented in every department, in every office, it's vital. It's vital. Otherwise, services are not reaching the people they need to reach, or the people they were designed for, or providing what's actually needed as opposed to what someone without a disability assumes is needed.
So again, just such a great example of what we talk about, what we hear in terms of disability inclusive healthcare and why that's so important for the state. And Rhonda, I am not seeing, oh, there it is. You're one step ahead of me. Thank you. So in our solutions report, which again has been posted in the chat by Nancy, we have a robust set of 10 recommendations. And then in the back, we have 15 additional recommendations as well. And these are just a few of them that really encompass what the state could do to really produce a disability inclusive healthcare system in Pennsylvania. So a few of these include involving people with disabilities, their families, and caregivers in all policymaking and healthcare decisions, increasing accessibility of healthcare services, providing information in multiple languages, easy to understand and easy to access formats, expand community-based healthcare, including telehealth services and mobile clinics, provide disability-specific training for healthcare professionals, and collect standardized data on the health needs of people with disabilities. So now I'm going to turn it over to our facilitator, Rhonda Beach-Tyree, to bring us through a couple resources and practices that you might be able to utilize.
Thank you, Emma. This is Rhonda. An internet search will reveal a good number of tools that healthcare organizations, healthcare practices, and systems can use to become disability inclusive, or at least to address health inequities in general. So on the left of the screen is a screenshot of a tool called Disabilities Impact Statement. And it's a planning tool that's available through the Center for Medicare and Medicaid Services website. They have a number of tools for addressing health inequities. And this one's just a generic action planning tool that includes areas of thinking about who are the populations and what are the health disparities that they may be experiencing. How do you define your goals and establish your organization's commitment to health equity? And then the focus on translating that into action and monitoring and evaluating that. And within their general description, they include individuals with disabilities as a part of that health equity planning, which sometimes we see is forgotten. In fact, we had a speaker earlier in our Lunch and Learn series who gave us a really powerful quote to say, when you're not doing disability as a part of your focus on diversity, equity, and inclusion, you're not addressing diversity. And so that tool is a powerful one. On the right, you see a tool that's more specific, and this one's offered by a collaboration organized by the Special Olympics, but it's also in collaboration with the Association of the University Centers of Disabilities and the Association on Health and Disability. And it's a focus on how to create inclusive health principles and strategies specifically for individuals with intellectual disabilities, and includes a number of principles and strategies to engage full and sustainable inclusion of people with intellectual development, so disabilities in your health policies, in laws, in programming and services, in training programs, and research and funding streams. That's a powerful one. There's a handout going in the chat with links to these tools. Look at the title on the right here, Disability Competence Care. Isn't that a powerful term? Disability Competent Care, a self-assessment tool. This one's one that's offered by Resources for Integrated Care. And it is, again, an evaluation and assessment tool to support planning for healthcare organizations, healthcare committed communities, agencies, practices, et cetera, to really take a person-centered approach. And on the left is an icon that they use that shares their core principles of disability competent care, that it is participant-centered, that it is built around respect for participant choice, and that it focuses on the elimination of medical and institutional bias. We've been talking about how stigma, bias, prejudice is such a key barrier for individuals with disabilities, and to have that elevated as a core value is powerful when you think about a mission of providing model of care designed to treat the whole person beyond a diagnosis, beyond condition. And their framework in this planning tool, Disability Competent Care, offered by the Resources for Integrated Care, is built on a set of principles, and it has sections in the tool that take the users through different ways of thinking about the first pillar, understanding the disability competent care model and participant engagement, how to create accessibility, think about your accommodations, reflect on those and plan for those. What are the implications for primary care? And another pillar is care coordination. And another pillar is long-term services and supports, and the complex care of behavioral health as pillars for planning. Here's a neat one. Language Justice Toolkit. This one's offered by the Communities Creating Healthy Environments. And again, the fact that it focuses on language justice, the fundamental right to multilingual and multicultural spaces where everyone's voice is heard, and it specifically includes sections and concrete practices on interpretation, translation to include language diverse individuals, is again, really powerful. That one's offered by Communities Creating Healthy Environments. This one is one that I wanted to unpack a little bit. It's called Disability Inclusive Health Services Toolkit. And it's a really practical guidance and tool for managers targeting managers and staff of healthcare facilities, healthcare practices, health policymakers, and non-governmental agencies to really identify and address the health barriers that are specific to people with disabilities. It's focused on universal health coverage by ensuring everyone can have access to health information and can benefit equally from the services that are offered. And this one's offered by the WHO, the World Health Organization, and specifically comes out of the Western Pacific region, but it has a lot of application. Let's take a look at how it's organized. It has modules, and there are training tools and there are planning tools to unpack these. And the 7 modules are Module 1, Disability Inclusive Health Services, getting started with some really powerful tools to help you think about what that is and frame conversations and reflection and collaborative engagement around what does it mean to be disability inclusive, or in the words of our other planning tool, disability competent. Module 2, promoting disability inclusive attitudes. So really addressing the biases, the stigma, the thinking, the lack of understanding and engagement and sensitivity. Or in one of our earlier working series, we talked about disability etiquette and understanding a person-centered, a way to the way you speak, to the way you engage, to the way you create culture in your healthcare organization. Module 3 is the physical accessibility, promoting universal design and reasonable accommodations, and what that means. Module 4, communication barriers, providing disability inclusive health information, something that the task force and regional community work groups in this project have called highly for. Module 5, disability inclusive health information systems for planning, monitoring, and evaluation. Module 6, what does it mean in terms of your rehabilitation approaches? And Module 7, what about emergency conditions? How do you prepare and apply disability inclusive health services in emergencies? For each one of those modules, again, there are powerful tools, but I wanted to just show you one organizational framework for one of the modules to show some of the tools that are available here. For Module 1, listed on the left, they have fact sheet, narrative, actions, and tools. These are available for every single one, and they're powerful scripts for each of those topics for, again, healthcare leaders, non-governmental organizational facilitators, or healthcare managers, practices managers, to really take the topic and unpack it. There are narratives available on topics, in this case, Module 1, like what is a disability and how do you talk about it? Why is it important for your health service to be inclusive of people with disabilities? And how would you talk about disability face significant barriers to accessing health services and equity. And how would you explore that? And it goes on and gives principles, for example, of thinking about how you frame and underpin disability inclusive health services. And then it offers a set of actions to think about and tools, again, including a checklist for every module on being able to walk your organization through an assessment. So again, there are a number of planning tools that are available, and we're excited to share these with you. We welcome, as always, for you to share different resources with us. Now, let's take a look at what disability inclusive healthcare looks like in practice. It's my honor to introduce Dr. Messonnieri. She is Chief of Psychiatry and Executive Vice President of Integrated Medicine at Woods System of Care. We have heard over and over task force members talk about what it is that's happening at Woods. They've been actively involved and our task force at the table. They provide comprehensive and integrated health, education, housing, workforce, behavioral health, and case management to more than 22,000 on their website, 22,000 children and adults with intellectual developmental disabilities. I don't mean they provide it on their website. I mean that's number latest posted on their website was 22,000. And those include individuals who have complex medical and behavioral health care needs. Dr. Messonnieri, welcome. Help us think about what does disability inclusive healthcare look like in practice?
Thank you, Rhonda. Thank you to ORCA Pennsylvania for having me today. I'm really excited to be one of the speakers today for this series of Lunch and Learn Disability Inclusive. Let me share my screen. Can you all see the screen?
Yes.
Yeah, good. Okay. A little bit about myself. As Rhonda mentioned, I'm Dr. Sailaja Messonnieri. I'm a board certified general and child and adolescent psychiatrist by training. I graduated, I did my residency and fellowship locally from Drexel School of Medicine, and then spent 20 plus years in practice. I was at Deborah Advanced Behavioral Health. I was the medical director for Children's IDD Services, a residential treatment facility in Westchester, Pennsylvania. And I also had tons of experience, different levels of care for individuals with intellectual disabilities and autism, starting from the diagnostic assessments to medication management, partial hospital programs. So before I came to Wood Services 2 years ago, I have gained all that experience. And as a treating psychiatrist, I have always felt that our system is fragmented. When I came to visit Wood Services, which was close to me because during my fellowship and residency at Drexel School of Medicine, I always wanted to be gaining the expertise and training in treating individuals with intellectual disabilities and autism. I have done clinical rotations at Wood Services, but because of the geographic location where I live, I have chosen, a place. Deborah was really close to my home, so that really was the plus point. But I stayed with this population. When I came to Wood Services, I was really, when I met our president and CEO, Teen Hansen Turton, I really felt that I could contribute to the model the Wood Services has, which is the integrative care model and the whole person centered care. So that's what brought me to the Wood Services, and it's been 2 years. Moving on to the topic today, we'll be discussing more about the integrated health services for people with intellectual disabilities and autism and mental health challenges, and what are the barriers for accessing care already a little bit of that. I'll touch upon the thing again. Sorry, I had to dance to get the lights on. And we'll also be discussing the integrated care models and the partnerships we have established at Wood System of Care and the policy implications. Just moving on to the who we are and why this is so important to us at Wood System of Care. A little bit about the Wood System of Care. We are a population health management organization, and we have a network of providers in Pennsylvania and New Jersey, and our goal is to provide life cycle care management to meet the lifelong needs of the individuals with children, individuals with intellectual disabilities and autism across the lifespan. And we also serve individuals with acquired traumatic brain injury in our Beechwood program. And these individuals also have complex medical and psychiatric conditions. And we have locations throughout Pennsylvania and New Jersey, and we provide them through Wood Services in Langone, as well as through our 10 affiliate organizations. Rhonda mentioned, I think we need to update our website, but we are currently serving 32,000 plus children, adolescents, and adults. This number increased because of our new affiliations that came through. And we get referrals from 175 school districts and from 23 states across the nation. And we currently employ 6,600 employees in our Wood System of Care. When I say affiliates, this is the slide that shows who are our system of care partners. For the sake of this is, I'll focus a little bit on what we are doing in Pennsylvania. Allies Abilities are focused in New Jersey. Bridgeway is our newest affiliate. They are in New Jersey. Allies has workforce development as well as that's through abilities, and also have group homes in New Jersey area. Archway programs are for private schools. Coming to the Pennsylvania, Legacy is one of our major behavioral health organization in New Jersey, offers a variety of services, and they have some innovative models partnering with the major hospital systems and providing behavioral health services in close proximity and sometimes within the hospital. They are currently with Wood Services are developing a county-wide mobile crisis program in Chester County, Pennsylvania, which is going to be rolled out in the first quarter in 2024, which is really exciting. Another newest expansion to our Wood System of Care is the Woods Community Services. We serve individuals with complex medical and behavioral health challenges in the community. We specially design these group homes gearing towards the individuals' medical as well as behavioral health needs, and that creates a model that hospital at home type of setting. Sometimes these are the individuals who are stuck in acute inpatient. It could be medical or psychiatric facility for a number of years. So, we are really excited to be able to provide this opportunity to these individuals to be able to live in the community. It definitely, takes a village to raise a child. So, we are putting a lot of services in place, and there is always a plan to kind of like ease them off of the services to be able to manage them a step-by-step progression, but be able to engage them more in the community. Always community integration is a key, and that's something we thrive towards. So the Woods Community Services also has an outpatient clinic, which is the Center for Behavioral Health at Woods, which is our recent expansion. We are currently credentialed with Magellan and waiting on a couple of other managed care organizations. We also serve individuals with intellectual disabilities and autism, as well as we do the autism diagnostic assessment and also provide mental health services to individuals without intellectual disabilities, right, population as well. We are excited about we have one of the affiliates, Woods Community at Brian's House, who have the community group home setting for the adults with intellectual disabilities. We are opening a satellite location for Woods Community Services at Brian's House, and we'll be able to provide outpatient services to individuals with intellectual disabilities all over Chester County, Delaware County. They can reach out to that location. We also have one of the other ones that really provides the integrated medical and behavioral health services and specialty care is the medical center at Woods in our Langone location.
Dr. Missionary, this is
yeah.
Ron. We're seeing the version with the small slides down the left. Go ahead and hit slideshow so that we can see your beautiful slides enlarged.
Let me see where we are.
Yeah. One way to do it is down in the bottom right by the slider, the one that looks like a presenter screen. You got it.
Yep, got it.
Much better. Thanks.
Thank you, Rhonda. Coming to the population, Woods system of care currently serves. These are the individuals, children and adults with the intellectual disability and autism and acquired traumatic brain injury. They have complex medical, psychiatric, and behavioral health challenges, and most of them require involvement by the multiple specialists. They may have comorbid neurological and genetic conditions that require ancillary therapies, occupational therapy, physical therapy, and speech. Seizures are a common comorbid condition, and they also have multiple behavioral health challenges. And coming to the, Emma covered a little bit about the prevalence of these intellectual disabilities and autism. There are across US, there are 7 million people in the US have intellectual disability. And we all know that the incidence of autism is growing up. As per the CDC, 1 in 36 children are currently diagnosed with autism. It continues to increase. In 2021, it was 1 in 44, and the striking number, significant increase, 1 in 150 in 2000. Who are practicing in the field of autism, we all know that there is increased awareness, and we are also getting better at diagnosing and doing the assessments early. That could be one of the factors, but may not be necessarily. We all agree that the rates are definitely going up. And 2.7% of the children in US are currently diagnosed with the autism spectrum disorder. And we all know that the boys to girls ratio is 4:1. Across the globe, there are about more than 1.3 billion people with disability globally. That is about 16% of the population. So it's definitely a significant number that what we are discussing about is the individuals who have some sort of disability, but mainly intellectual disability and autism. And what are their complex health needs, and why do we discuss about the physical and mental health for this population? Because there are 40% of the individuals with intellectual disability and ASD, they have a co-occurring psychiatric condition, and 45%, as per one of the data sets, 45% of the Medicaid beneficiaries they have with intellectual disabilities and autism have additional co-occurring chronic medical condition. So there is a complex interplay between these physical as well as the mental health conditions, which can make the overall care for this population is really requiring multiple providers. There is there should be a true integration between the medical as well as the behavioral health specialist to design any treatment plan for them. Similar to this other aging population, that the geriatric population, one study, the polypharmacy rates are really high, and which they carry their own risk because of the drug interactions and also the side effects that they cause for this population, which can exacerbate the behavioral health challenges, and not knowing the behavioral health specialist may add more medications. The integration is really important to minimize the polypharmacy for these individuals. And they also require more monitoring for negative impact on physical health. If they are on psychotropic medications, it could be side effects, or in general, because of the psychiatric condition, they may not be able to follow the treatment recommendations given by the primary care physician, and not able to contact them in time. The list goes on. And they also tend to be the high utilizers for the emergency rooms and inpatient hospitalizations. Emma covered some of it, disparities in access to care. What are the barriers to access? I think most of the providers, they do their office setup and physical space, and most of the times the exam rooms may not have the ability to accommodate physical handicaps, and also lack of training definitely makes a big difference. They may not be trained to really address the communication or behavioral challenges that occur in the office setting, and they may not be adequately equipped to handle if the behavior occurs. They do not have on-site, especially people who are extremely sensitive to the light, sounds, or the crowded environments. Most of the office settings are not equipped to handle those kind of things. And also the reimbursement rates are really low. And these individuals with intellectual disabilities and autism, they do take more time, especially getting the collateral information itself takes a lot of time to get the information, and the providers cannot afford to serve them because of the low reimbursement rates. And because of all this, and also because of the co-occurring medical and psychiatric conditions and lack of access, could result in the multiple ways to health disparities. We know that there is a shorter life expectancy for these individuals with autism and intellectual disabilities because of the comorbid medical conditions as well as the genetic conditions. They have higher rates of epilepsy, gastrointestinal, and other kinds of sensory disorders. And they require higher rates of emergency room visits. And they have also, one study showed lower rates of immunizations in this population. Cost of care definitely is much higher compared to the general population. Adults with intellectual and developmental disability with ASD spend annually 5 times more than the general population. Over the course of a lifespan, the cost of care for individuals with the co-occurring IDD and autism spectrum disorder is about 2.4 million. And individuals only with autism, it's about 1.4 million when you compare it to the general population, that's 188,000. And when you think about if they have a complex co-occurring medical and psychiatric condition, that's the population we serve, the lifetime cost of care for these individuals is close to 6 million, a significant jump. How do we change and make it more cost effective? 2 ways that we have been discussing this part. We need to address the barriers to access and also work on what we have been doing at Wood Services. I'll get into more in-depth detail, develop inclusive and integrated care model so that we are developing one treatment plan which can help with reducing the costs and also unnecessary procedures, unnecessary higher levels of care for these individuals. And what we have been doing and what we know is that how do we change the system? One of the things that we have, we advocate people to support the Healthcare Extension and Accessibility for Developmentally Disabled and Underserved Population Act, which is a shortcut Heads Up Act, which was introduced to the Congress in May 2023, which will allow for the HRSA to designate people with intellectual disabilities as medically underserved population. And that'll open up more than about 25 government programs support to the individuals with intellectual disabilities, and also work on building, training, educating the healthcare workforce, and also improving the systems for data collection, and also work on developing the regulatory policies and equity standards for this population, and develop more community level supports to address the needs of these individuals and to maintain them in the community. And I think post-COVID, this has gotten worse. Everywhere is the huge challenge is the workforce. Globally, several healthcare workforce, people leaving the profession has increased significantly, and we are all struggling with the direct care workforce. This could be because of the shrinking adult working age population and also growing aging population. And what it really means is that the impact is at the community level. There are long wait times for these in-home services, especially behavioral health services, and they have long wait lists. And all of this results in the long-term stays at the acute levels of care and also poor health outcomes. And just to, when you think about the disability, what are the models? This helps us to figure out what's the integrated care model, how it works. There are three models that were theorized. One is the medical model, which is, when we were in medical school, we were told that, when a person has a disability, this is the medical theory, that this happened to the individual. A problem at the T4 or a disc level, or he has a paralysis, or his muscle weakness sort of thing. So it was mainly, this model was theorized to fix the problem and improve function. In kind of like in 1970s, a model that was utilized was social model, where we were talking about there is a disconnect between the environment and the individual. So we were focusing a lot on fixing the environment, making it disabled friendly. But when it moved on to the 90s, we developed the biopsychosocial model, there's a typo there, which recognizes that there is an interplay between the psychological, social, and behavioral dimensions to the medical condition. And that is the basis for our integrated care model that we have developed at Wood Services. And when we think about when we discuss integrated care model, what is it really? What are the providers doing? This is a kind of like a tool, integrated practice assessment tool. We use it at our location. It kind of gives us an idea of what is the integration between the physical and the behavioral health components. The first level 1, level 2 are sort of like the physical health provider and the behavioral health provider are not at the same location. Sort of level 1 is like a minimal kind of integration when we discuss exchanging the records, or requesting a copy of the consult note or something of that sort. Level 2 is even though they are not at the same location, but they have kind of like a arranged phone calls between the providers to discuss the treatment plan for this individual, or going back and forth. There is some level of collaboration. The next category is level 3 and level 4, where we are discussing the services are co-located. They could be in the same building. There is physical proximity, and they are discussing some level of collaboration between the providers on an ongoing basis, that they may have like a set meeting and they exchange notes, and also discuss the treatment plans, or some level of integration is there. That's the co-located. Integrated is within the same office location, there are providers in the same building and they share the same office, they share the same electronic health record, and they develop a comprehensive treatment plan that addresses both physical as well as the behavioral health challenges. We are in that category currently. Our medical center and the Center for Behavioral Health, we are working on a electronic health record platform. In the next quarter, maybe in 2024, we'll be achieving the full integration with that part. What does it look like at Wood Services is, what do we do, is the continuity of care to accommodate the changing needs of the individuals. And we provide a whole person integrated care approach model. And all our providers are trained and have experience working with this population. And our waiting rooms and also the exam rooms are very disability inclusive and sensory friendly. Our exam rooms are much larger to accommodate the individuals as well as their families and the staff members or the team members that come in. And we are also very thoughtful with the appointment scheduling. We leave extra time for our providers to be able to take time to really assess the individual and obtain the collateral information. And also we provide, if we need to contact the outside providers, we do that at the appointment time, which is a huge step in developing the treatment plan right there and then, not wait for 2 days later or something. And also we provide a data-driven approach, and we are continue to advocate and work on the healthcare policy needs. I'm not going to get too much into this slide, which is basically what we are taking when we are working on developing the treatment plan. We are taking into consideration the social determinants of health and also providing that patient-centered approach. The patient, the client voice and the family voice drives the treatment plan. And we work on developing those and tailoring those services to meet the needs of the individual, and also provide that full life cycle care management. And this is our enhancement to the system of care, integrated health services. That is the picture of our medical center at Woods, where we provide comprehensive medical as well as specialty care to our individuals with intellectual disabilities and autism, both residential clients as well as we are open to the community as well. We also have the ancillary services such as the radiology as well as phlebotomy within the medical center itself. It's like a one center, one stop at the medical center. We also have the podiatry and optometrists coming to the medical center to provide those services. We partnered with the Penn Dental Medicine, and we they also train the future training dental residents, which is a huge step in sending them into the community with experience in handling individuals with intellectual disabilities and autism. And we also opened the Center for Behavioral Health at Woods, which is our mental health outpatient clinic. Within the Center for Behavioral Health at Woods, we have the Center for Autism, where we do the initial diagnostic assessments for autism, ADOS, as well as psychological testing and also treatment recommendations for levels of care. And at the Center for Behavioral Health at Woods, we also provide psychiatric evaluation, med management, individual and group therapies, and it is open for individuals with psychiatric conditions as well. It does not have to be an individual with intellectual disability or autism. This is the medical center at Woods. We have the NCQA recognition, which we are really proud of. And we, as I mentioned earlier, we provide integrated care, primary care, behavioral health, specialty care. We have a neurologist comes on every week to see the individuals who have the neurological conditions. And also we have the dental clinic adjacent to the medical center. And we have developed extensive partnerships with the academic institutions, and we provide opportunities for the residents, family practice residents, as well as the physician assistants and nurse practitioner students, a preceptor opportunity at the medical center. And we also provide for the psychiatric program, residency program, residents from Temple University, as well as the Tower Health psychiatry, child psychiatry fellowship program rotations on our campus. I think that's a huge step, as they have that opportunity to really able to work with individuals with intellectual disabilities and autism and during their training, which is a huge step. It was huge for me. It was my personal experience when I did my rotations at Wood Services. And we also provide care coordination across specialties, health systems, and they are able to transition them between levels of care. Another transfer, these are the academic institutions that we have partnerships with. Synergy is our pharmacy that we utilize. They are that's a huge step, integrated with our medical center as well as with the residential. And that really provides an opportunity for our providers to really look at and create polypharmacy checklists and being able to minimize the use of the medications. One of the things what we have been, I think I touched upon a little bit about meeting the individuals where they are, and also building a lot in the community and trying to move them along from the acute levels of care to the least restrictive environments and maintaining them in community-based settings. What the transformation is really for the past 2-3 years, what we have looked at is the residential levels of care. We have transformed them to the short-term active treatment programs. When they are referred to us, most of the times they're coming from acute levels of care and they have failed multiple community-based levels of care, and also presenting with the intense behavioral challenges especially in our children's programs. What we have taken an approach to change them to the transitional active treatment model, which is we really work on addressing the behavior, stabilize them. And the day one, we start with the discharge planning process. It could be home with intense in-home services, or to another community-based levels of care if the in-home, good returning home is not an option. With the opening of the community, with the opening of the outpatient clinic, and we are able to quickly transition them. Our plan in 2024 is to develop in-home services under the Center for Behavioral Health at Woods, which will provide opportunities for the easier transition for these children to return home. And we also work on generalization of the interventions to the home setting. We involve the parents early on, or if we identify a discharge resource, it could be a foster parent, adoptive family, or another provider. We start training them on the interventions that we are utilizing in the residential levels of care. So that's a huge step that we have taken to quickly move them along to the least restrictive levels of care. Also, we are working with different hospitals and with the state in developing those complex group homes for these individuals who have been staying or stuck in the hospital forever. For the referrals that come to us have been in this acute inpatient setting for a year or two, which is not the quality of care that we really that we need to really address, is to develop an individualized program for them so that they can transition home. Some of them, the hospital at home model, which talks about individuals with in complex medical conditions, they may be requiring event support. So we have been looking at developing that intensive nursing model that we can transition, being able to provide that level of hospital level of care in a community home setting. And also we are working on crisis stabilization and prevention. We are working with an inpatient hospital right now to develop a kind of crisis stabilization as well as an inpatient setting for these individuals to quickly move, being able to be screened and move them into the acute inpatient for stabilization and work on discharge planning process. As I mentioned previously, one of our affiliates, Legacy, is working with Wood Services and developing a mobile crisis team in Chester County. And we are actively looking at telehealth models to serve the western part of Pennsylvania. And what is the integrated treatment approach really entails? It's we as the providers, and I train the nurse practitioners as well as the psychiatry residents and child psychiatry fellows on the data-driven medication management. An individual comes to you with behavioral challenges, a lot of times it's the knee-jerk reaction from the provider to, prescribe a medication. A lot of times that's not what they really need. We need to look at what's going on in the environment and what the triggers are for the behavior, and really obtain the data, complete a functional behavior assessment, looking at the triggers, antecedents to the behaviors, and develop interventions. When the medication to be used only when it's necessary. And in that way, we are also minimizing the polypharmacy. And a lot of time I spent on educating them about the interactions between the medications. And the most of the times, our population is really extremely sensitive to some of the psychotropic medications, and they also can impact the physical health. And also taking into consideration that there could be a medical condition that can be exacerbating the behavioral health condition. There is an interplay between both of those conditions. A lot of times addressing the medical condition can alleviate the behavioral crisis that's going on at that time. So, taking into all these factors before, they open up and start prescribing Risperdal or some other stronger medication for behavioral to address a behavioral challenge. Just to give an example of what just I described, this is a case example of a 17-year-old female with the autism spectrum disorder, intellectual disability, and significant mood dysregulation, presented with irritability, aggressive outbursts, leaving the program area, needing multiple restrictive procedures, definitely more intense in school than at the residence. We were consulted, just to give, most of the times we look at reviewing the medical records, and obtain the collateral information and the behavioral data and look at the incident reports. We also discuss the behavioral issues that were happening, obtain history from mom. And what we have recommended is look at the functional behavior assessment, what's going on at school and at the residence, what are the triggers. And once the function of the behavior is identified, we develop a treatment plan. It was mainly denied access and task demand situations. She was engaging in those behaviors. We develop interventions to address those. And also a lot depends upon developing a protocol or the implementing the interventions consistently. So actively engaging in training staff is very important in developing or implementing any behavioral intervention plan, and obtain the data consistently. And what we found out that her mood dysregulation or the fluctuations really coincided with the start of the menstrual cycle. We consulted the primary care physician, and we were able to prescribe an oral contraceptive pill, and we did not need to utilize any psychotropic medications, but we started looking at what other medications that she was on, which could be contributing or escalating the behaviors. This is just a typical one of the case examples for the integrated care, working with the integration between the medical, clinical, and the school teams, and with the residential teams. And when we discuss the integrated care model, what are the key characteristics? There is a high level of communication and collaboration between the primary care, the specialist, psychiatry team, residential, nursing, and clinical teams. That is the interdisciplinary treatment team approach. And every intervention will be discussed in those meetings, and each treatment team member is aware of the interventions. A lot of times when we are starting a medication, we inform the clinical team, and so that the clinical team can take data regarding if the medication, the start of the medication, any change in the behavior, whether it's improving or worsening. In that way, we are able to really capture if the medications are causing any kind of adverse reactions. And also, we collaborate with the outside agencies and also to fill in those gaps in the services so that we can start working on a discharge plan or to provide a continuum of care for these individuals, and integrated electronic health record, which is in the process. The benefits are improvement in the quality of care and enhanced access to services, and also reducing the healthcare costs and reduced number of visits to the emergency room, and also minimizes the number of unnecessary tests. And our individuals with intellectual disabilities and autism, they're very overstimulated in a traditional kind of emergency room setting or any kind of medical procedure. So eliminating the need for those services definitely improves their ability to cooperate with other types of testing. Some of the things that we have adopted at our at Wood System of Care is to train and support the next generation of providers, all type of professionals. It was starting from the child psychiatry fellows to residents and nurse practitioners and physician assistants, medical students, nursing students, and staff. At every level, we trained them and also introduced them to the our population, and providing the technical assistance for health system and hospitals to be more disability friendly. And recently we have embarked on we have visited a few places in India and Dubai to look at their mental health, and we were asked to provide the technical assistance for those hospitals in those areas. We are looking into developing the global centers of excellence at Wood System of Care for mental health, autism, and intellectual disability, and also we are looking at better data collection systems for all aspects of health and disability care. And also, we are actively looking into partnerships to build and provide more services to individuals across Pennsylvania. We are actively looking at Western Pennsylvania and across the globe. And I'm open for questions and answers. And thank you for having me today.
Thank you, Dr. Missionary. This is Rhonda. Are there questions? You're welcome to put them in the chat, raise a hand, or just open your mic and speak. Any questions? All right,
Wow.
I have a question.
please.
Sure.
Kathy.
Go ahead, Kathy.
There was so much great information. Thank you so much. I was trying to make notes as quickly as I can. But my first question, I have many, is when you do technical assistance for healthcare systems, if there were healthcare systems, say in the northern tier of Pennsylvania, and providers that weren't currently in your reach, is this something that would be appropriate for them? And how else would you suggest providers and healthcare systems that aren't connected with you yet, so they could just use some of the magic that you've produced?
We are actively, Kathy, we are actively looking into developing that telehealth platform as early as January, February of 2024. So I constantly work with and develop and train psychiatry providers. So, what we have done here, we would like to replicate. That's one of the things. So the telehealth platform what we have been developing will be able to do the consultation basis. We are actually providing consultations to provider organizations nearby, within travel distance. But if they are not within travel distance, we can definitely use the telehealth platform. And one of the things we have been looking at, if, for example, Western Pennsylvania, 3-4 hours away, or so I am a big about in-person kind of evaluation at least once in a quarter. So our provider could go into that area once in 3-4 months, or can do an in-person evaluation, which could be valuable. And we can also provide that team, what I described, the interdisciplinary team approach. We could be a part of that interdisciplinary team and provide that technical consultation, and kind of like a one-time, maybe it's a complex case, and we can explain and the process. And maybe once they have the data and their clinical team is working on that, we can develop that treatment plan and help them out. So there are both ways. We could provide the direct psychiatric consultation, behavioral consultation, staff training via the telehealth platform with one in-person visit every 3-4 months. And also we can provide that if they're struggling with a complex case, a technical consultation model, being a part of that interdisciplinary team, gather information and provide the recommendations, and they can follow through with their current provider if they have an existing provider. So those are the 2 lines of service that we can offer.
Thank you so much.
You're welcome.
This is Rhonda. There's a question in the chat from Christy. I see you opening up your mic, Christy. Ask it for yourself.
Hello, this has been really interesting presentation. Thank you so much for sharing. Can you talk at all about the time frame? I'm sure you did, but can you say it again? How long did it take to develop this program, and how long has it been operational?
The telehealth?
The Woods program overall.
Oh, Woods program, we have been in existence. We are already providing services here. The Center for Behavioral Health outpatient services, we have residential services, which was the start. I think we have transformed into, we have the medical center here. The whole Woods Healthcare is fully operational.
And it's been fully operational for some years now?
Yes,
Okay.
since, yeah, only community outpatient clinic for psychiatric and the Center for Autism this year, 2023. But the medical services and the integrated health services have been for some time. They have been only open, the medical center is only open for individuals with intellectual disabilities and autism. But on the other hand, the Center for Behavioral Health, we do see normal population with psychiatric conditions as well.
Sheila, bring forward your question about incentives.
Sure, thank you. And a really wonderful presentation, just so well done. And you thought it through every step of the way. And then I get down to the incentives part, how we can help to advocate for change. So what do these incentives look like, that you're thinking would really bring the system up to speed? Because we have a lot of work to do, in a lot of different places in Pennsylvania.
Yes, I think the first thing I was discussing about the access to care. I think, we don't have the data systems in place to really look at where the services are really lacking. And, we provide, some of the managed care organizations have, a couple of them approached us that especially when we are looking at the discharge, are stepping them down. They are sitting in our residential treatment facility, not because of their behaviors, because of the lack of services. So that's where we really need to advocate for providers to, and a lot of times it's the staffing one thing, and another thing is the trained providers who can handle the individuals with intellectual disabilities and autism. So I think the future goal should be to improve that access to care, have more providers identified, and look at what are the payment models. Really, it should be like a value-based or versus, the standard reimbursement rates, they won't be able to financially be viable. We need to look at what other technical, just like I described the telehealth model, maybe we need to think outside the box and come up with some of those, kind of provide the technical assistance to those organizations so that they can handle these complex individuals. What we have been developing here, we can definitely replicate anywhere else. So the incentives could be in the reimbursement rates and also having access to that care, which can make a big difference.
Thank you. Thank you.
Other questions? Dr. Musuneri, any closing comments for you? And then we'll turn to Emma to thank you.
I think I'm really, thank you for having me here. And, we all are in this together. And I really appreciate ARC of Pennsylvania for all their efforts for the disability inclusive. And, we all can make our voice heard and make it really big on developing that integrated care model, and also eliminating the barriers to access to care. So whatever we can do from one system of care perspective, let's all work together.
Thank you so much for participating today and sharing all that information with us. We really appreciate it. And thank you to everybody, our participants, for joining us today and having this discussion and having those questions. It really means a lot to us over at the ARC of Pennsylvania. Just before we break today, I want to have 2 plugs for some summits that are going to have a lot of interesting discussions about and furthering the discussion that we had today. So one is hosted by the ARC of Pennsylvania, and that is happening on March 6th of 2024 up in Harrisburg, Pennsylvania. And that is our Disability Health Action Summit. We're going to have some amazing speakers and amazing discussions that day. The next summit is the 2024 Health Equity Summit, also in Harrisburg on April 4th and 5th of 2024. And that is hosted by the Pennsylvania Department of Health, Office of Health Equity. I know that there is a breakout session during that focused on disability health equity. So that's going to be really interesting, and I'm excited to see who the speakers are for that summit as well. But again, thank you guys so much for joining us and for attending these lunch and learns. They've been so insightful and educational, I know, for us over at the ARC, and I hope it was the same for you all. And I hope everyone has a great, happy and healthy holiday season, and stay warm and safe if you're traveling. So thank you again, and we will see you hopefully at our health summit.